Real quick, since we're a smaller group, I won't keep you over, I promise, but I just want to do a little, thank you, a little round of introductions in the room, because I think that's the benefit of smaller groups and conferences in general, just to get to know who we all are. So you heard from Mark. Is it Jen?
Yep.
Yes.
Perfect. I'm Jennifer. I also work with the American Red Cross, and I'm an undergrad at Crescent.
I'm Barb Long. I'm a nurse, and I work with the Red Cross.
I'm Jocelyn. I'm a student at UNMC in public health, and I'm doing my capstone with the Red Cross.
I'm Andy Gleason. I work here at Creighton University for the Institute for Latin American Concern. We work with
my name's Nick. I'm a P2 student in the School of Pharmacy here at Creighton.
Candy Hoffman, and you're the English practitioner in Washington.
Nice. Good
I'm
couple.
Temple. I am a teaching physician out of Creighton. I am based at the VA Hospital.
I'm Humble. I'm an MPH student at UNMC.
I'm Bella. I'm a high school student at University of Michigan.
Nice. Where's the Innovation Center at?
It's in Grand Rapids.
No, oh, nice. You came from afar. Welcome to Omaha. So I'm Jono. Really just an hour-long discussion. It's more of a multidisciplinary approach to how we looked at the Ebola response. Fortunate to have graduated from Creighton for undergraduate, so I feel at home on campus. We didn't have this nice building here, nor was I a business student. So it's nice just to be back on campus. A little bit by way of background, and then I'll talk mostly about the response itself. I start off by usually thanking the public health officials that really helped me reintegrate back into the United States. My partner, Andy, I'll share a little bit of our journey as I was getting ready to leave for the response itself, and a little bit about how the integration back into the United States was by far the hardest part for me as a responder to the response, and not necessarily the 30 days that I spent in Monrovia. This is just a little capture of what Sarpy County Health did for me. Just yesterday, I still go to lunch every other month with my public health nurse, who monitored me for 30 days. Monica is a phenomenal soul and human being, not knowing what the experience would be like, largely because of the media, who really had varying degrees of welcoming and hospitality towards medical professionals for putting their own lives at risk and coming back to the United States. So I always like to just pause there, and typically I have somebody from public health in the audience that can really appreciate this. I'll talk a little bit more about specifics how that works, but I've been a Red Cross for a long time. I grew up in the Red Cross system and haven't left it. It seems like it's just part of my blood. These are my way dated back cards that I still keep around like a geek, dating back to when I was in high school before I could technically drive the vehicles. But started off with lifeguarding and CPR and first aid, and just really had a liking to the mission of the American Red Cross, and specifically what the movement is about throughout the globe. The HODAT is the Heartland Orientation to the Disaster Action Team. It's the team that responds to house fires and everything that basically happens on a routine basis. But grew up in the Red Cross system, had a lot of diverse experiences, both domestically, and I'll share a little bit about the international experience, focusing mostly on Liberia and the Ebola response. But it's really been filled with lifelong memories. I've spent many birthdays on disaster relief operations, given up holidays, lots of milestones in life, largely because, tying it back to Dr. Anthony's kind of discussion around passion, there's really an underlying passion, I think, that probably fills each and every one of us in terms of why we've chosen the work that we're doing in this field. Lots of life-changing moments that I've had the fortune to help communities in time of need. Sandy Hook, Sandy Hurricane, you name it. Find myself at the crossroads just because of the demands of the community to really help recover. I often start off by this because people usually ask me why Ebola, why go to Liberia, why put your life at risk, your loved ones at risk, etc. And I date back to actually a nurse that I was on deployment with back in 1998. And this nurse, her last day on the operation in a small town in southwest Iowa, Hamburg, if you ever go up Interstate 29, said to me that she had something special for me. And what she did on the last day of the operation is she pulled out this sheet of paper that I have nicely framed in my office. And she said to me that when she was a little girl growing up, she was probably early 70s, her home economics teacher gave each of the girls in the class, she went to an all-girls school, a book with a little written note from the teacher in it that really describes what she felt embodied that child. And this is what her teacher gave to her, and she wrote to me. And it says, you have to give yourself to life before you really live. It's foolish hoarding love or wealth, those lose who never give. And as a health professional, she really made a lasting impression on some of the eventual choices that I would make. Going to undergraduate at Creighton, I studied political science, didn't know what I wanted to do, so I went on to become an economist and thought, yeah, it seems like a good graduate degree, but still didn't know how it was going to plug into what I was really passionate about. And that leads me to a little bit about the story of Ebola. So fast forward, most everybody in the room, I know Jocelyn has done research around the U.S.'s response to the Ebola outbreak in the United States. It really was a surreal experience because as a natural disaster responder, I had always planned for public health emergencies. I had worked with public health officials. But in the United States, we've always been fortunate enough that it's never reached a level that mirrored anything that I found myself really coming up against and really finding myself in last January. So Liberia itself, a little bit of the demographics up here, very, very poor country in West Africa, really struggling with decades of civil war from 89 to 1996, and then only after a less than three year period of peace broke out into another round of civil war from 1999 to 2003. And the city, I like this particular building. This used to be one of the only multi-story buildings in Monrovia. And my first days on the ground there, just some of the pictures that will never leave my mind had less to do with bodies that were impacted by Ebola, but more so about the poor infrastructure that led to the eventual perplexing cause of the spread of the disease. And those holes in the building aren't atrophy or just old buildings. Those are bullet holes, they're mortar shocks. And these are in roads and bridges all across the city. This particular building was right across a key river that the two regimes that were fighting were considering a sacred place because of the space that was in it, and it was a strategic place. But average per capita, I often pull out my cell phone, and the average per capita in Liberia is the cost of a cell phone to anybody in the United States. And it really put that into perspective as we were starting to figure out how to deal not only with the medical component of the Ebola response, but my particular mission was dealing with what's called economic security. In a very vulnerable part of Africa where just north of Liberia, there is lots of concerns around civil instability, terrorism, and anything that destabilizes the economy, like an Ebola outbreak, has the risk of destabilizing a population, causing people to seek other activities that will support their families, feed themselves, and keep themselves alive. So just kind of a relative perspective. The country itself has a very unique history with the United States. They have counties within the country. They're English speakers, largely because in the brief history of the United States, we took slaves from Liberia and then we sent them back and gave them their own independent land back. So there are a lot of descendants in Liberia that affiliate. They have American names. Several of their counties are named Maryland County, and other things that would be very recognizable. Which was a fascinating history to me. In fact, the slaves that came back from the United States were considered to not be true Liberians, and it has created a social chasm between the populations. The current president, Ellen Sirleaf Johnson, first female head of state, phenomenal credentials, but one of the tensions within the country is that she, two grandparents ago, had grandparents, great-grandparents that came from the United States. So this is fascinating, even though she's born there 2 generations. So it's an interesting dynamic. So a little bit about the International Red Cross community. Red Crosses are broken out into 3 separate parts, not to bore you with details, but people will often see things like the American Red Cross, which is one of 186 national societies. There's the Canadian Red Cross, and the Mexican Red Cross, and the German Red Cross, the Liberian Red Cross. There's 186 independent national societies. And then there are two other distinct components. One is what's called the International Federation of Red Cross and Red Crescent Societies, not to bore you, but their primary mandate is to alleviate human suffering outside of areas of international armed conflict. And then specifically in areas where there is armed conflict, could be armed conflict, or has been armed conflict, there's what's called the International Committee of the Red Cross and Red Crescent, or ICRC. The ICRC has a very specific mandate in trying to promote stabilization in areas of violence. In particular, from a legal perspective, under the Geneva Conventions, where there are areas of what's called international armed conflict. Certainly with Liberia, it wasn't national armed conflict, but there was conflict within the country. And so the ICRC has had a permanent mission, one of the 79 that we have in Liberia, since the initial Civil War outbreak in the late 1970s. So fascinating for me as an American. The Americans, typically from our Red Cross National Society, don't go to areas of armed conflict because one of the components that we violate traditionally is that Americans are seen as non-neutral. And part of the International Red Cross, Red Crescent movement is that we're neutral and impartial parties to conflict. So we don't take sides. We don't engage in the political chasms between governments. So traditionally, American Red Cross can't send an ICRC delegate to Iraq or Afghanistan. But because of the unique nature in which we found ourselves an ally to Liberia and the friendliness towards Americans, it led me to this particular mission. So a little bit about the role of the Red Cross movement in Liberia. Because we had a permanent mission in Liberia, fortunately, President Sirleaf, when she won the election in 2007, 2008, she worked diligently to stabilize the government, and there has not been armed conflict in Liberia since her administration took over. So you fast forward to the Ebola outbreak, and there were many concerns from the international community that this could indeed destabilize a country that has unfortunately only spent a short period of their lives really working towards peace and non-conflict. So there were elements of our Red Cross movement that were starting to destabilize, that were starting to demobilize would be a better word. And we found ourselves asking the question, what do we do as a conflict-based organization in the midst of a medical emergency when, quite frankly, there was a lot of slowness within the international health community to actually mobilize resources. And there are many discussions and literature reviews around the international health community's reaction to Ebola, particularly at the root cause within the western parts of Africa. So the International Red Cross and Red Crescent said, we have to do something. We have people there. So I'm going to talk distinctly about the missions that we saw ourselves in. So one is in the area of protection. I mentioned to you that the ICRC typically visits places that are war-torn and engaged in international armed conflict or international conflict. And traditionally, one of our primary tasks is to visit detention facilities and to assure that the rights afforded under the Geneva Conventions are being given to the individuals that are actually being detained, no longer engaged in armed conflict, what they call an unarmed combatant. So the idea, anybody familiar with the Geneva Conventions? I don't want to assume anyone's a geek in the room. So the Geneva Conventions were really affording soldiers that no longer engaging in conflict to basically be afforded basic health care, the right to practice their religion, the right to their families, humane treatment, uphold human dignity. Those are kind of the big keywords in the Geneva Conventions from the 1800s. And one of our primary tasks, as we were traditionally doing prison visits in Liberia, was to ensure that Ebola didn't get into the prison system. This is a picture of the largest prison in Monrovia, the capital, that I visited. And you can see it doesn't look like a U.S. prison, probably no surprise. There are nearly 200,000 people that pass through the prison system a year within Monrovia, of which there's only about a 20,000 bed capacity. Okay? So put it into perspective. Obviously, with the public health concerns, our question was, what is being done to train detention officers, to train administrators, how to prevent Ebola from coming into the prison and wiping out an entire population? It's an interesting place for an NGO to be in, because most people don't want to fund work that treats prisoners well. It's not a compelling case. You can't put Sarah McLachlan on a TV with crying puppies. and replace that with crying prisoners. People typically don't have as much apathy towards that, right? So our mission is very unique in that sense. And what we did, this is one of the Liberian correction officers working with the Department of Interior who oversees the prison systems, is teach prison officials good public health practices within the prison. So if you're familiar with Ebola virus, one of the key indicators of the virus was a fever. And so we did prison monitoring, teaching locals how to do prison monitoring, and also safe and sanitary washing practices, both on their feet and on their hands. Ebola is a very weak disease in terms of being able to prevent it. A little bit of chlorine. I'm not a doctor, so I say a little bit. It is very diluted amounts of chlorine, and the only side effect of that is I had dry hands for an entire month. We teach the prisoners how to prevent touching. There was a no-touch policy in place throughout the country, which culturally is very hard to enforce because people are used to hugging, they're used to touching each other, we're human beings. In particular in this part of the world where family practices, especially for those that lost loved ones, the practice is to caress your loved one, to hug your loved one, even when they have deceased, which of course is not good from a public health perspective. So a large part of our work was spent teaching officials how to prevent the disease from coming into the prison system. We also had water and sanitation engineers. This is one of my colleagues from Egypt who spent inordinate amounts of time in the prison system making sure that they had access to clean water. The issue was not that we didn't have enough chlorine. The issue was not that we didn't know how to stop the disease. The majority of people in Liberia don't have access to water. And water is the key ingredient in diluting the chlorine to help prevent the disease from actually spreading. So water and sanitation engineers were key in making sure that we were actually helping within the prison system, and I'll talk a little bit outside the prison system. We also had an assistance program. Interestingly enough, because ICRC, we have physicians and nurses and anesthesiologists and nutritionists on staff, we had a very unique requirement. U.S. government came, many of you read about this, and provided a huge lift to the humanitarian assistance that was needed in Liberia and Sierra Leone and Guinea. But the key question that came up from the medical professionals is, what are the nutritional standards for people that have Ebola? What's their caloric intake? How much of it needs to be starches versus proteins? And there was a lot of questions being asked through the World Health Organization and other NGOs that had very specialized care, like Doctors Without Borders, and nobody really knew. It was new enough that they were kind of making it up. But because we had subject matter experts in the field, both that understood the local culture, we had local nutritionists from within West Africa. The U.S. government contracted with ICRC and said, help us figure this out. Help us figure out how to feed people that are in the Ebola treatment units, ETUs as I'll refer to them as. And so we came up with standard recommendations on cure kits, electrolyte balance, etc. It's pretty fascinating. Our chief physician, it was making evidence-based decisions in real time because you didn't have a lot of time to figure this stuff out. So we not only distributed these packages to those that were impacted by the disease, but also the survivors. And I'll talk a little bit about some of the symptoms that survivors were portraying. Prevention action, this is the only public health hospital in the country. I was absolutely shocked. When I came, it was fairly late into the operation, but yet you could still see piles of rubbish, and this is from Ebola treatment units, because they didn't have incinerators. They didn't have safe and well handling practices for biocontainment. So a large part of the ICRC's role was to train local medical professionals and volunteers, largely the Liberian Red Cross, and how to dispose of waste within the Ebola treatment units and within the only public health hospital within the country. Very, very unique space for the ICRC to fill. We had a Danish water and sanitation engineer, the only Caucasian in the picture there. The rest of those gentlemen are Liberian Red Cross volunteers. About half of them either had a family member that died or very few that actually survived. And they felt compelled, without compensation, to do something for their country to stop the spread of Ebola. Relative context, 90-degree temperatures, in Tyvek suits, protective equipment for long periods of time, and the downing procedures required them to change out their outfits 3 to 4 times a day. And the several experiences I had in working with them, you can see their boots. When they would come out of their boots in the afternoon, they'd be ankle deep in sweat, just from the heat, not only from the natural climate, but a large part of the ICRC mission is we shipped in 2 large incinerators, humongous incinerators, one of which was dedicated towards bio-waste containment and removal, and the other was, unfortunately, for cremation, because the country did not have the resources to cremate, which I'll talk a little bit about in terms of cultural sensitivities in a vast manner. Ministry of Health, obviously overwhelmed on a good day. One of President Sirleaf Johnson's comments, if you think back to what I said the GDP was per capita, $400 per person to $500 per person, she was being criticized on an NPR interview shortly after I came back from the U.S. about waste and abuse in Liberia. And she put it this way. She was happened to be in D.C. when she was taking this interview. She said, "I want you to understand that I inherited a country that has a GDP less than the high school that I passed to get to this interview this morning." So put that into context in terms of why there are so many challenges in the country, why people feel that they have to fraud, waste, and abuse in order to feed themselves. And it's just a relative perspective in terms of how we found ourselves at this kind of crossroads. These are water and sanitation engineers actually removing waste from biocontainment units, the Ebola treatment units. The symptoms for those that were passing the virus, a lot of waste, fluid waste, and it was incredible the constraints that it placed because there was just simply no place to put it. And that's where our water and sanitation team was working with the international community to help set up systems. I want to talk about diplomacy. That part's pretty boring, but because we are neutral and impartial, we spend a lot of time making sure that we're invited into countries. We have good permanent relationships with delegations, and not in Liberia, but in other parts of the world, we make sure that we maintain that independent seat within the state. A large part of our mission was enabled using local leadership. This is the Director General of the Liberian Red Cross, and a fascinating part of our community mobilization strategy and getting the message out about how to best avoid passing the disease was really through community education in the highest risk areas. This was one of the towns near our delegation, one of the what we call the hot zones or the red zone, that people unfortunately live so close to each other that it's hard not to touch one another, let alone the cultural practices. And we knew that we couldn't send people like me into the neighborhood to tell them, don't touch each other, don't hug each other, check your temperature. It was most effective with their neighbors. And so we spent hours, days, months building a community mobilization plan to make sure that the community was getting the message out there. These are just some of the practices. The other key mandate that we had with the Liberian Red Cross is we did the safe and dignified burials for 4,000 plus. These stats were right before I landed in Monrovia, but for 4,000 plus bodies that were collected. Nobody wanted to do it. There's not an emergency medical system where you could just call an ambulance or a coroner, things that we take for granted here in the United States. And we had people uncompensated, I want to emphasize that, volunteers that were putting their lives in harm's way because they knew it was the right thing to do for their country and for humanity. And the people that were picking up these bodies were absolute heroes in my mind. And just their soul, I'll talk a little bit more about that. That was the social mobilization. A large part of psychosocial support was making sure that we had emotional and spiritual care available, mental health professionals, because this takes a burden not only on volunteers, but the entire community. Ironically, 2 decades of civil war hardens people. I shared with Andy when I would often Skype back that I didn't see one tear the entire 30 days that I was there, aside from my own, where at night I just had to decompress a bit. And it was amazing to me. I would ask kind of local delegates that were Liberians, a little bit about why people that were impacted so harshly by the disease were visibly untouched, almost stone-faced, and much of it was cultural. And Christopher, who was in our economic security department, said, if you can only imagine something 10 times worse than this, then you can imagine why this is just another thing in our daily lives. And it was really stark for me to imagine that there was something that much worse over 2 decades in the country, that this is just one more salt in the wound, but not quite as bad as it was during the civil conflict. A little bit about what I found to be interesting from a policy perspective. This was these are some quotes taken from our head surgeon. The aim in mass casualty situation is to do the best for the most, not everything for everyone. And this was certainly the case with Ebola. There were limited resources, there wasn't enough time, there wasn't enough material, there wasn't enough coordination to make a system that was perfect. But the policy that was adopted by the international community was the best for the most. And a large part of setting up the Ebola treatment units was trying to figure out how to best coordinate where Ebola treatment units were stood up, who was managing them, and then priority patients are those with the best chances for survival. Interesting from a very sociological, anthropological perspective, family members, because of the stigma attached with Ebola, were dropping their loved ones off anonymously because they didn't want to be seen as that person with a family member with Ebola. And there are countless stories that I could tell around simple abandonment of bodies. They dropped them off at all hours of the night, on the curb. You'd see bodies piled up on the side of the Ebola treatment units because family members were scared that they would be evicted. That was a huge problem from housing. And the housing, you can remember back from those pictures, isn't like a 2-story brick house. It's a shack. But yet people were still being evicted from those shacks because their landlords felt they posed a public health risk. So where do they go? Huge problem. This is just a little bit about the stats, and I'm not going to bore you with all the visuals, just in consideration of time. You guys will have copies of all these. I'll leave you my contact information. Highest concentration, these were some of the stats when I was there. Obviously, the victory lap that we did this summer was huge in terms of containment of the virus. Montserrado is where the capital is, and you can kind of see some of the other communities that were impacted. Interestingly enough, although there are no cases in the rural areas, that is largely by way of which the statistics were captured, because they were captured in the area in which they were reported. And most people wouldn't report in Lofa or in Nimba because there are no treatment facilities. But yet, in order to get care, they would have to come into the city. So the numbers were a little bit skewed. They were tarred with the Minister of Health to better assess where the root cause was, because obviously just because somebody leaves Nimba and comes to Montserrado doesn't mean that there's still not a risk in Nimba from a tracing perspective. These are just some of the social indicators that we were looking at. I like to talk this morning because it talked about key metrics and indicators on how we measure progress. So we developed dashboards within the international community looking at social mobilization, like getting the message out there. Don't touch your dead loved ones. Don't touch each other. Take your temperature. Report high fever. All the things that we knew would work. Monitoring bed capability, psychosocial requirements. That never got better. That never got better because the majority of the international health funding was going towards biomedicine. It wasn't going towards social, psychosocial interventions, which is unfortunate. The Carter Center, I applaud them. Carter Center had a decent amount of funding that actually stood up a delegation there, and their sole focus was psychosocial. They set up a survivors support network that I participated in, where people that had survived the disease had basically found themselves a safety net to come and talk about it because there were a lot of considerations after their treatment. Contact tracing, this is like Where's Waldo? You know, if I said that I had Ebola or I presented signs of Ebola, we did the good old-fashioned tracing so that we would find out how many hot cases may be out there. Body management, and then the other big piece that often got hidden was non-Ebola treatment. There was no place for anybody that had any other symptom to go, and it was much worse than it normally was. The healthcare facilities weren't great other than that. And the other piece for the medical folks in the group is that Ebola has the same symptoms, initial onset, as many other things. My number one fear was to get a cold or to get the flu, or to get just like a little basic infection, like a sinus infection. Because the minute I showed signs of a fever, that was it. It triggered a whole series of other events. And of course, it makes you a little bit paranoid, because every once in a while your fever goes up, especially 90-degree temperatures. You have to make sure that any time that your temperature was checked, you were sitting in the shade for a while so that you didn't present symptoms that could otherwise be treated as Ebola. And they had good protocols in place for that. Non-medical support, huge logistics lift. I mentioned that before, incinerators, other PPE equipment, nutritional things that were being sent in, water and sanitation, all the other non-medical components were being coordinated at a very macro level, as well as what we called consequent management. And I'll talk a little bit about my specific role, and then want to open it up for some questions. But a lot of the pieces I was focused on were food security tied to economic impact, because markets were open. I was proud that the government didn't do what a lot of other places did, which was shut down borders, kind of close the economy, if you will, which has severe spillover effects in terms of people's economic security that can lead to additional violence. So I'm not going to talk about social mobilization, case management, because these are all very good numbers, but it will kill you if you have to try to read these up on the board. The kind of course of my time there, certainly we had good days and we had bad days. All it took is one new hot patient that touched a loved one or their family members, and we could see a spike of 25, 30 cases within a day, because it was that easy to actually pass and to actually transmit. Deaths, same thing. We certainly did not have many periods where we were in the low end. There wasn't a day in January we didn't lose somebody due to Ebola or Ebola-related concerns. The body management piece was absolutely vital because of the concerns around waste that came from the bodies and the carrying of the virus. So in coordination with the Ministry of Health, that was one of our chief tasks, was to do safe and dignified burials, to make sure that family members knew where we were taking their loved ones. That was a 3-month problem at the initial onset, is that people's loved ones would be taken away. They didn't know where they went. They didn't have any chance to say goodbye or to pay respects to that particular loved one. So we brought in a lot of good psychosocial experts that were setting up systems that would allow for a more dignified approach, of which one of the most controversial policies was cremation, because cremation is not socially accepted, it's not socially tested, and there wasn't equipment to cremate. And the burial site outside of Monrovia was 50 miles outside of the city. Which doesn't sound like a lot to anybody that lives in a metro market or in the United States, because we have good roads. 50 miles could take 3, 4, 5 hours, depending on if it's raining, if it's not raining. Most people don't have vehicles. So the chances of actually seeing their loved ones at the burial site was slight to none. The economic issues were rather fascinating. Here are a little bit of the health indicators, 3 medical facilities that we help support in terms of maintaining their safety, infection control. We did focus a lot on maternity care, the non-Ebola stuff, because mothers were saying we have no place to take our soon-to-be-born child. So we wanted to be sure that there wasn't this secondary or tertiary effect for individuals that didn't have Ebola suffering from diminished care. Last night at the reception, I was sharing that one of our most successful practices was partnering with Liberian physicians. In the entire country, there's about 25 physicians. Okay, 25 physicians. Pretty massive lift for those 25. They lost all but 9 of those physicians due to Ebola virus. So those 9 that survived, the majority of them partnered with the Red Cross movement to help us to continue the mission. The medical school had to close. Obviously, a lot of them were faculty at the only medical school in Monrovia. And they were helping us focus on the system outside of Ebola to make sure that that system wasn't collapsing as well. Also trained healthcare workers. There were nurses and individuals that had medical backgrounds, both degreed and non-degreed, that we would partner with in order to mission enable the treatment. And my specific program focused on this piece called economic security. And I mentioned why before, but we knew that people that had either survived, the very few that did, or those that had passed, their family members were extremely vulnerable in the community. They were ostracized, they weren't being talked to. We have good data that suggests that up to 80% had to leave where they were living because of social stigma or a concrete eviction. 80%, if you can imagine, large-sized temples.
Was it because of fear of getting the disease or just?
I reference this as akin to what was happening in the 1980s in America with HIV/AIDS, but only worse. Because at least in the United States, HUD said you can't discriminate based off of certain things, right? There's no HUD. And it was absolutely heartbreaking to see that level of discrimination based off of fear. I mentioned the prison system, so I won't cover that again, healthcare access, and specifically I want to talk a little bit about the cash assistance program. So very unique. There's a lot of distrust within the funder community about handing out cash in third world countries. There's this tradition in humanitarian relief that we must hand them something. You know, it's accountability. If I hand Temple this water, I know that she's thirsty, therefore the intervention is effective. She needs water. And the funder community has been long criticized for assuming that Temple needs that water instead of something else. Because we know best, especially Westerners, right? Caucasian Westerners. We know what the communities actually need. So very controversial within the International Committee of Red Cross. The Federation's been doing cash programming for years. The American Red Cross has been doing cash programming for years. But within areas of conflict, there's a lot of distrust by government in particular around giving people cash. They're not going to use it wisely. They're going to make bad choices. When the data suggests that even if we give them the water, if Temple doesn't need the water, what's she going to do with it?
Sell it.
She's going to sell it. She's going to sell it to get what she needs. And water is probably not the best example in this particular case, but we do tarpaulins, we do jerry cans, we do comfort kits, we do all these things that we assume people need. And one of the Liberians that I had a focus group with, who was quite animated, he said, "Don't scratch me where I don't itch." And that was his key message. He survived Ebola, and he was sharing with us the experience of all the aid organizations wanting to give him mattresses. And that was the example that he used. Other NGOs, they knew that people were having housing problems. So as a collective, they said, well, they need mattresses because they had to destroy all of their things when they were admitted into Ebola treatment units. Their houses were decontaminated and destroyed. Everything inside them. So the NGO community said, we're going to give them housing kits. We got 5 housing kits, right? 5. He's like, no one asked me, do I need another housing kit? Third one came, do I need another housing kit? And that saying will forever, ever stick with me. So I'm like, that's a really good point. So we took a risk. We knew that our donors would support the idea if we provided good data, and suggesting that in partnership with the government of Liberia, we wanted to strengthen resilience and give people their dignity to decide what their course of recovery looks like. Wow, imagine that. Trusting people, assuming that people have innate dignity and humanity inside them, that they can make their own choices. And cash programming, as controversial as it is, there are such strong research points that suggest that it's the right thing to do for the community for a number of reasons. This is one of my favorite pictures, a little gory, but this is the reality check of what Ebola treatments look like. So, no kidding, you heard me reference that most people would just drop off their loved ones without identifying who they were because they did not want to be attached. And that was 60-70% of people that were dropped off. No identity. If they were well enough, because they just caught the fever and are just being identified as having Ebola, they might be able to identify themselves. Most people that were arriving at Ebola treatment units far past that state. They couldn't talk, they couldn't identify themselves. If they had identity on them, almost every one of the Ebola treatment units would throw it into an incinerator and destroy it because it was contaminated. So we had an entire population that had no identity, no documentation, And the medical professionals that nailed this early on established this deliberate process to try to identify and trace people based off of key indicators, forensics, body marks, so that they could eventually, especially with memory loss that was associated with Ebola, go back to the communities and say, do you know who this person is? That was a small percentage of people that could not remember because of the treatment, but there nonetheless weren't great procedures in place because the medical professionals that rushed in, especially if they weren't asked by the government of Liberia, they had one objective, and that was to save lives. And they weren't thinking about consequent management in terms of registration and documentation. I often make a plug when I talk about this experience to Doctors Without Borders, because Doctors Without Borders had by far the most professional registration system. Recognizing this was going to be an issue. So that if I left an Ebola treatment unit, I could eventually be eligible for benefits, because one of the concerns is you can't issue benefits to somebody that we don't know if they really were impacted by Ebola or they really weren't. Because once they leave and they're homeless, there was a 6-month wait to replace birth certificates for the government of Liberia. 6 months. And that's if they could prove identity. And go back 20 years of civil war, a lot of vital records were lost for a lot of generations of people, that it made it virtually impossible to identify who they were. But MSF encouraged all Ebola treatment units to set up documentation procedures to make sure that that was mitigated. Amazing. They even gave people certificates, and they celebrated as people were leaving Ebola treatment units. It was part of their healing, their spiritual healing, and being able to say, we made it. Pretty sweet. So here's who we targeted. People who were cured, the unfortunate few, families of the deceased from the community, and then families of the deceased in the Ebola treatment unit. We specifically chose Ebola treatment units. LWA 2 and LWA 3 were names of 2 of the Ebola treatment units based off of where they sat within the community. The reason we did not choose the other Ebola treatment units is for the reason that I talked about in the previous slide. There was no way to document whether or not people in the unit who were being treated were actually who they said they were, and we had to hedge a little bit of the risk we had from our donor community in saying, you've got to be able to show some accountability for how you're using these funds. The unfortunate, I think, dissonance between the humanitarian community and the donor community, which is we just want to do the most good with the most things, and they say, well, yeah, but we want you to be able to account for it, right? And the previous speaker was talking about the dynamics between grant funders and grantees. So pretty fascinating. We did $200 installments in 3 payments, 160 and 40. Amazingly, we did all of this through SMS cash transfer, which in the United States, in the domestic Red Cross, we joke, we don't even do that, right? But in many places in Africa and Central America, people may not have a phone, but they have a SIM card. And their SIM card, they usually carry in their pocket, and it's like their little lifeline. It's not that big. But they carry it with them. And traditionally, when they want to make a phone call, they'll go over to the neighbor that has the cell phone, they'll switch out the SIM card, and they basically make the phone call. But there was a vast amount of data that suggested that the easiest way and most dignified way to get cash to people was to use this mobile-enabled network. Traditionally, humanitarian aid organizations would set up what they call encashment stations, meaning they would stay on Saturday the 1st, anybody that's eligible could come and receive their cash payment. Well, think about the dynamics around stigma that are attached with Ebola. Now we're asking people to essentially identify themselves as victims of Ebola and to possibly be prosecuted by their neighbors, their friends, their family. And from a pure human dignity perspective, we knew that people wanted to maintain a discrete profile. And so this allowed us to simply register them using their number. To verify their number, we partnered with the cell phone company to make sure that if Andy said that he was eligible for payment and this was his number, that the cell phone company said, yep, this is who is registered with this particular number. So there were dual controls that were put in place to make sure that we could report back. This was what we were trying to maintain, empowerment and dignity in a community that had had decades of dignity removed and stripped away from them. And a lot of the individuals, we said, here are some things that you may want to consider, but we're not telling you how you have to actually use these funds. So the difficult part, if you look at 4,000 plus affected, the difficult part was not being able to find all of them because people sometimes said, we don't want to be identified. We don't even want the financial assistance because we're fearful it's going to expose us as having had Ebola. I mentioned the relocation statistic, 70 to 80% of people relocating. So this was extremely challenging in trying to trace people once they left Ebola treatment units. And the vast majority of people that it wasn't about tracing them once they left, it was about tracing their family members because they died and not knowing who dropped them off or who their brother was or who their sister was. Impact, this was largely the work that I stood up in January. I showed up January 2nd, and I had a good day to set up a monitoring system. So we did beneficiary sampling, I did focus groups, and here were some of the comments that were made. This was from a local resident. She said the ICRC is like a god to her. They came to her aid. And these were just trying to gauge impacts. Typical story, this was one particular person. Her husband left because of Ebola. She also took over 11 and 10-year-old orphans because the family next door had the mother and father that had died. She was put out of the house where she used to live, and she has 6 children on her own. So here you have one female, unemployed, Ebola survivor, with 2 orphans and 6 children. Very typical story. This one really caught my attention. ICRC made a great impact in my life. She did small coal business. This is Liberian English. That's what I learned. Although they speak English, I had to really pay attention because it was a variation. The stigmatization also caused her to almost commit suicide. And this was all over the place. People that were just on their last leg trying to stand because they had made it through the Civil War, and now, just as things felt a little bit better under President Sirleaf Johnson, they felt like they were getting blown a really tough punch to the stomach. But a lot of the partners that are listed in there, Doctors Without Borders, Médecins Sans Frontières, was listed as really having a key social impact as well. So kind of opening up for questions, I think what I found interesting about this mission in particular was the pride that I had in knowing that the U.S. government made a very tough political decision to actually go to the root cause of the problem. And Justin and I have talked about this a little bit. We spent millions of dollars in the United States panicking for good reason, based off of what people were seeing. I'm convinced, I have to take off my red hat for a minute, my Red Cross hat, it was very political in decision for people to panic as they did. Because there were so many differences in terms of basic infrastructure between here and Liberia and other parts of West Africa. And to have an administration that was willing to say, we're willing to go and put ourselves at risk, knowing that that's the way that we're going to solve the problem. We can't just build a wall around the United States and keep Ebola from finding itself in the United States. But it was a very calculated decision. When I was getting ready to leave, knowing that I had not worked a public health emergency, when I was talking to my partner, I really struggled because this is not my core competency. Economic security, got that, but the interface of that in the public health community, in the medical community, was certainly dynamic. I found it to be very educational, but most importantly, everyone was there for the right reason. Countless physicians and nurses and other medical professionals that I talked to that, they put themselves in harm's way much more than I did. I never had to don or down my equipment because I was never interfacing with individuals that had active cases, only survivors. And a large part of that was reflecting. There are 2 things that I keep on my desk. One is that yellow thing that I showed you at the beginning of the presentation, and the other, I had a colleague who always says, your mission is greater than any of your programs. So a lot of humanitarians that I meet that are kind of entering into the business, they get stuck in their program. This is what I do. This is the program that I administer. These are the grant dollars that I receive. And often I'll ask them, well, what's your mission? And it goes back to what Dr. Anthony was saying yesterday about your passion. So I try to remember that as we're asked to go into these situations as professionals. And the other piece that really stuck, I like old abandoned buildings. You saw that initial picture. So on weekends, I would often go exploring the city, and one of the buildings that I climbed, it was safe, one of the buildings that I climbed was the first 5-star hotel in West Africa, that happened to be in Liberia. It was built in the late 1960s, really started to flourish in the early 1970s, and then with the Civil War, obviously lost its prominence. And at the top of this building, there were probably 2,000 to 3,000 people that were killed in this building during the Civil War because citizens that didn't have anywhere else to go all fled to this particular place in hopes that they would be able to avoid the brutality that was taking place. At the very, very top of the building, at the onset of the Ebola outbreak, somebody spray painted this, and I thought it was just very indicative of the Liberian spirit and the culture in Liberia. And it says, "We're all fireworks, rising, scattering, shining, and finally fading." And so much of their existence has been about being a resilient people, not giving up hope, despite all the blows that they've been given over the past 25 years. And I like to stop by saying thank you to the U.S. government, my U.S. government, for making that tough decision, and the international aid community for actually doing something for a part of the country that often doesn't get a lot of attention. It's easy to turn a blind eye and focus on building capacity here in the United States without getting to the root cause, which morally and ethically I struggle with. And certainly my Sarpy County health professionals who called me for every day for 30 days and asked for my temperature. And because I cover so much territory in the United States, I was never in Omaha for more than a day or two. And that public health professional called every county health department where I traveled and let them know that I was visiting. And I never felt assaulted. I never felt like there was a bias. But it really was amazing to be able to see this amount of progress when the collective good of humanity comes together. Government, private funders, non-governmental organizations. And really just an amazing experience. So I'll stop there and really just answer questions or see if there's any dialogue in the room. Got about 10 minutes left.
Since I'm involved with giving assistance to people after fires, and I know our little formula we use. So the lady who took in the 2 orphans and had 6 children of her own, what did her assistance look like?
So for each individual or surviving family member, we provided $400, and we did it 2 ways. We started off with an initial $200 tranche, and that $200 was broken up, a little convoluted, but in $100, $60, and $40 over 3 months. I'll talk about why. We then came back 6 months later and did a flat $200 payment. The reason that we broke it up that way, because there were Westerners in particular that would say, why don't you just give them $400? And we would have to explain that there's this phenomenon in economics called income shock. We see it in domestic disasters where people without resources all of a sudden find themselves with lots of resources. And there's very much a behavioral change. Not necessarily negative, but it can cause anxiety, it can cause panic. People that have never found themselves with $400, that's a whole year's worth of salary for so many people. So each individual we treated uniformly based off of that calculation.
So she received money for the children as well as herself. Okay.
Yes, so if the children, the 2 orphans, they would be registered as one case, so that'd be $400. And then because she also lost a family member, it was an additional $400.
Okay.
So we were able to treat it as 2 cases or 2 households. And that was part of the difficulty, is that you would have families of 10, and because only one person was impacted, it was $400, or you could have a family of 2. And if you were impacted, you got $400. So in that case, we were able to split it up into 2 distinct cases. Yeah.
Yes, coming from a kind of a medical anthropology perspective, how do you interface with either healthcare professionals or Liberians or other professionals, social science professionals, kind of bridge the gap between ICRC movement and Liberian culture, or kind of Western humanitarian systems and Liberian culture or government? How important were those professionals, or who were they, or were they volunteers?
It's a good question. A large part of the International Red Cross movement is using indigenous resources. We even use it domestically, like our preference when we have a disaster in Montana, is to mobilize Montana volunteers because they know their community. And both the Liberian Red Cross and the ICRC delegation was predominantly, well, in particular, Liberian Red Cross, there may have been one Westerner per 1,000 volunteers. ICRC was a little bit different because of the dynamic of international armed conflict during the two periods of violence in Liberia. So the ratio was a lot less. But we still surged Liberians working as local hires within the delegation because we felt they knew their communities best. So the local physicians that we picked up from the medical school when it was closed, picked up teachers and nurses from the local community. And I think that was a magic ingredient. Honest to goodness, we have local drivers, which may sound a little odd, but they know the roads. But most importantly, they could tell you anything you wanted to know about the communities in which we served. Anything. The one driver that I had detailed to me started with the movement when we stood up the initial delegation in '79, had been let go last year, or a year and a half ago, pre-Ebola, because we were closing the delegation, things were peaceful, and he got his job back once we surged. He was extremely valuable. Extremely, because he explained to me the dynamic between the president being seen as a foreigner, even though she was 2 generations in Liberia. Those are things that you can read about, but they just don't make sense unless you have the context. And I think it's a magical ingredient for us on every operation. Some people know this, but I primarily specialize in Central and South America when I was an international delegate in Panama. So this was a new part of the world for me. It was a part that I hadn't even studied in the textbook. So to have that indigenous knowledge made my mission much simpler. People that I spoke to on a daily basis when I would call home knew it was extremely frustrating for me. I can go in and set up a massive feeding operation or economic security operation in the U.S. 24 or 48 hours. I can get systems in place and finances in place and push stuff out the doors. You can't do that in other places. And so meeting people where they're at, gently encouraging. One of the frustrations was that we weren't working weekends, personal frustrations. And I thought, this is a humanitarian aid crisis. And yet we had local hires that weren't working on Saturdays and Sundays. And I hit myself when I finally realized they've been going at this for 8 months. And these are people that live 2 hours away that take buses to get to the city to have the privilege to work for $5 a day. And I beat myself up after thinking, some of these westernized thoughts, because Bar's been Red Cross operations, like we can set these things up overnight. Hurricane Sandy was a $350 million enterprise, humanitarian enterprise, and it stood up overnight, over a course of a week post landfall. And yet, as a Westerner coming into the culture, sometimes we make assumptions. We have that cognitive bias around, how long it takes. Jocelyn?
Yeah, I just had a question on recovery. I've heard arguments on both sides of this. I just wanted to hear your thoughts. For one, the health system in Liberia will be worse off because of the burden that it's had, but then on the other side, the training and the nurses that have been set up, will that actually strengthen in the long run?
So I'm a firm believer that with every disaster, there are opportunities if they are systematically embraced at the socio-political, economical level that can make communities better. Domestically, communities like Joplin and Greensburg are better communities, safer communities, because of the embracing of that vacuum that disasters create, public health disasters in particular. There are some socioeconomic conditions that don't exist and political will that don't exist post-disaster that I think exacerbate that other argument. I believe that there's a good recipe brewing in Liberia because of President Sirleaf's administration. If you haven't read about her, she's just absolutely an amazing individual, and she has another year and a half left on her administration. What worries me is what happens after, right? So the tax base is extremely fragile. People self-report. They don't have like an IRS. So when you think about the economic engine of most communities, it's revenue that's tied to a tax base in some way, shape, or form. And there are bulletin boards all over Liberia. Don't forget to report your property. Don't forget to report your income. Now, how many people would actually do that? They've had good market progress that she's taken office, but even her own brother, when I was there, was being accused as a state legislator of not reporting his taxes. So I think there has to be, there's an algorithm to make that possible versus my work in Haiti. There isn't the alignment of socioeconomic and political variables that suggest that after Haiti, there are opportunities. Andy and I were meeting with a colleague with Department of Homeland Security, and we had worked the Haiti disaster together, and one of the keen interests that the U.S. government had post-Haiti was trying to get into Port-au-Prince within the first week to help spread Western business ideology in hopes that it would stick. Now, I have mixed moral dilemmas about that, but the idea was maybe if we get in there during this chasm, that it can be permanent, that we can structurally influence what rebuilding looks like. And unfortunately, the literature suggests that those are sometimes the best spaces to make permanent adjustments, permanent alignment. And certainly domestically, I've seen that work tremendously. You know, the domestic version I like to use is after every flood, there are finally conversations at a local level around how to use mitigation dollars to help people avoid flooding again. The great 1993 floods, which kind of got me interested as a kid in this whole disaster work, the same homes aren't flooding over and over again because government, nonprofits, and other interest groups said we've got to buy people out of floodplain areas. And now, you know, kind of translate that to that administration, and within that year and a half that's left, I think there could be remarkable progress. Yes,
How did you integrate into the ICRC coming from like an undergrad graduate like program? Like, how did you choose that you wanted to work there, and how did that happen? Like the application process, like what does that take?
Sure. So I started with the American Red Cross, the youth volunteer, that disaster action team. Never thought I'd work for the organization forever. And when I found myself actually working for the organization, I was really postgraduate, decided that there was a local opening. There was an emergency services director position here in Omaha, and that was my first entree. I was working in private banking, and had my broker's license. Life was good, especially in that era. This was like pre-2008 bank collapse. I mean, this was the heydays. And I'm like, moral dilemma. My parents thought I was crazy, you know, because here I am taking a...
Your mom never said that.
Oh, my dad did. My mother's the soft side. Barb knows my mom. And while she may have great pride, I think there was fear for my own well-being growing up. Working for a nonprofit, we change a lot. We contract because of limited resources. But on the international side, in 2005, they put out a call at American Red Cross to join their international roster. And I'm like, yeah, I have, my studies were in Central and South America. I'm going to try this. So they did an extensive interview. I went to what they call basic training. And they do a week-long exercise where just by going through the training you're not in, they observe you. And they test you, and you work long hours and overnight, and they want to see how you react to stressors, because that's a key indicator. I can't tell you the number of people I've met that are good-hearted that say, I want to do international work. And I'll say, well, do you have a passport? And I'll say, well, no. I say, you want to Nebraska? No, but I want to. I'm like, start with Canada. Start with Mexico. Start with the DR. But don't assume that you want to do this. You become callous. You have to become callous in a certain way, otherwise you'll break down. So went through basic training, and the commitment was every year I'd have to be on call 3 months out of the year and go at least 1 month out of the year. So I've kept that up. In 2007 to 2008, the Red Cross contracted domestically, and they were fortunate. I was fortunate, and they were humble enough to ask me to go to Central America for the year. And then I came back domestically and continued that obligation. But I think the best, for anybody getting into this business, the best thing you can do is just throw yourself in it in any way, shape, or form, whether it's short-term volunteer experience or ILAC, studying abroad. There's good experiences that are lent from even those short-term immersion experiences that I think can lead into this world of international humanitarian work.
Thank you.
Any others? We're right at the top of the hour. I don't want to make you guys late for
So did they
lunch.
reopen the medical school?
The medical school is reopened. Mm-hmm. It is. In fact, because of some of the funding from the international community, IMF, the African Bank sent a large amount of capital to help support a sustainable educational system. But the physicians there, just their stories are heart-wrenching. Absolutely heart-wrenching. I wish I wasn't scared of needles. because I would have gone into this profession. But I'm definitely afraid of needles. Blood didn't bother me, nothing else. But thank you guys for coming. Enjoy the lunch hour. If you guys get bored in the afternoon, come back.
Back downstairs.
I think so.
Oh, I have one of those.
Oh, panel discussion.
Oh, no lunch yet.
No lunch yet.
No lunch.
30:47. Thanks. Yeah, I appreciate it. Sorry, I was trying to send people to lunch. For some reason, I'm an hour ahead.
No, that's okay. We're all a little off.
So I'm going to 30:47 for